Okay, so welcome back to the deep dive. We're completely changing the format today.
We are.
Yeah, we're turning the heat up. I mean, way up.
Hmm.
If you're listening to this, maybe you're on your way to the hospital, or you're in the break room, or maybe you're just, trying to keep your head above water in residency.
We've all been there.
Absolutely.
Yeah.
But for the next hour or so, I need you to mentally check out of wherever you are, because we're entering a simulation.
That's right. Today we are stepping into the exam hall.
Specifically, the MD anesthesiology exams.
Mm.
And I'm playing the role of the nervous, probably slightly sweating postgraduate student who just wants to pass this thing.
And I'm the senior MD anesthesia faculty at Gujarat University. I'm the one with the clipboard looking over my glasses at you, deciding your fate.
Oh, great. No pressure.
My job isn't just to grill you, it's to make sure you're safe. Because the topics we're tackling today, muscular dystrophies and infantile hypertrophic pyloric stenosis, or IHPS, these are not just textbook chapters.
No, these are physiological minefields.
Exactly. You're not dealing with small adults here.
The margin for error is basically zero.
And that's why examiners love these topics. They test everything all at once. Your understanding of deep physiology, your grasp of pharmacology, and most importantly, how you manage a crisis.
So if you make a mistake in real life, it's catastrophic.
And if you make that same mistake in the exam, you fail. It really is that simple.
Okay, so let's set up the syllabus for this trial by fire. We're drawing from the heavy hitters, right? Miller's Anesthesia, the latest edition.
The 10th, yes. We'll also be pulling from Robbins for the deep pathophysiology, Morgan and Mikhail, and of course, the classic long and short case summaries.
Got it. It's a lot of ground to cover.
It is. But if you walk away from this session with nothing else, I want two things seared into your brain. Two golden rules, two mantras.
Okay, I'm ready. Lay on me. What's the first one?
Mantra number 1. In Duchenne muscular dystrophy, succinylcholine is a lethal weapon.
Not just avoided, a lethal weapon.
It is absolutely unequivocally contraindicated. You even mention it as a possibility, and you're done.
Got it. Succinylcholine equals death in Duchenne. Okay, what's number 2?
Mantra number 2. Infantile hypertrophic pyloric stenosis is a medical emergency, not a surgical one.
Medical, not surgical.
You never, ever rush that baby to the operating table, no matter how much the surgeon is shouting.
Okay, those 2 sentences feel like they could save my career.
They just might. Now, shall we begin the examination?
Let's do it. Oh, your O.
Introduction and exam framing. Oh, your O. Oh, your O.
So, Professor, if I can call you that, sticking with the role play, why these 2 topics? I mean, out of all of pediatric anesthesia, why are examiners so obsessed with DMD and pyloric stenosis? It feels like one of them comes up every single year.
It's not tradition. It's about identifying safe practitioners. Look, in anesthesia, we do a lot of routine cases. But these 2 conditions, they strip the routine away completely.
They force you to think beyond just the drugs.
Exactly. You have to be an internist, a geneticist, an intensivist, and an anesthetist all at the same time. It's not just put them to sleep, wake them up.
Right.
Let's talk about that high-risk label. Why do we call them that?
What?
Let's take muscular dystrophy, specifically Duchenne. What is the one outcome we are absolutely terrified of?
Sudden cardiac arrest on induction.
And what drives that?
The hyperkalemia, the potassium spike.
Precisely. It's an unseen metabolic time bomb just waiting for you to push the wrong drug. You push that drug, and 3 minutes later, you can have a flat line on the monitor.
And with IHPS, with the pyloric stenosis, the risk is different, isn't it?
Completely different axis of risk. With IHPS, we're worried about perioperative apnea and profound metabolic chaos. You're dealing with an infant who's been vomiting for weeks. Their electrolytes are a mess.
And if you don't fix that mess first?
If you induce anesthesia before fixing that chaos, the baby may not have the drive to breathe again after the surgery is over.
That's a terrifying thought.
So, you see, one tests your pharmacology knowledge under pressure. The other tests your understanding of fluid and electrolyte management. They test the core pillars of our specialty.
So how does this actually look in the exam? What are the patterns?
Well, you'll see it in a few ways. First, there's the long question, your 10 or 20-mark essay.
Okay.
The prompt will be something like, discuss the pathophysiology and anesthetic management of a 5-year-old boy with Duchenne muscular dystrophy scheduled for a tendon release procedure.
So they want the whole journey, from the faulty gene all the way to the recovery room.
They want the full story. Then you've got the short notes, these are more focused, anesthetic implications of DMD, or describe the metabolic derangements in IHPS. They're looking for crisp, High-yield bullet points there.
And the Viva.
Ah, the Viva. That's where we lay the traps. We ask very specific questions to see if you are a safe practitioner. We're not just testing knowledge, we're testing judgment.
And I'm guessing in an OSCE station, they could just throw up an ECG or an ABG result?
Almost certainly. You might see an ECG from a young boy with unusually deep Q waves in the lateral leads.
Looking for that cardiomyopathy.
Exactly. Or an arterial blood gas from a 4-week-old showing a pH of 7.55 and a bicarb of 32. If you can't look at that and immediately know what's going on,
You're in trouble.
you're losing marks, and more importantly, you're showing you can't recognize a critical clinical picture. Whoa.
Muscular dystrophies.
No? Oh, okay, let's dive into part B then. Muscular dystrophies. I'm sitting in the exam. First question. I need a solid, confident definition. How do I start?
You start with the fundamentals. Muscular dystrophies are a heterogeneous group of inherited genetic diseases.
Heterogeneous meaning there are many different types.
Many types. But the two key features, the hallmarks, are progressive muscle weakness and degeneration. The word progressive is vital. It gets worse over time. It doesn't get better.
And for the exam, while there are many types, we really need to zoom in on the dystrophinopathies. That's the key term, right?
That is the high-yield territory. And within that group, you must be able to clearly distinguish between the two main forms: Duchenne muscular dystrophy, DMD, and Becker muscular dystrophy, BMD.
Okay, so let's break that down, Duchenne. I know it's the more severe one.
It is the severe form, yes. It's an X-linked recessive decoder.
Which means it almost exclusively affects boys.
Correct. And the fundamental problem, the core issue at the molecular level, is the complete absence of a functional protein called dystrophin.
A complete absence, not just a little bit, but none.
None. And without dystrophin, the muscle cell membrane, the sarcolemma, cannot withstand the stress of contraction. The onset is early. Parents usually notice something is wrong between ages 3 and 5.
And the progression is, well, it's brutal.
It is relentless. These boys are typically reliant on a wheelchair by the early teens, around age 12 or 13. And without significant modern cardiorespiratory support, survival beyond their 20s or early 30s is unfortunately rare.
And Becker, how is that different?
Becker is the milder cousin. It's caused by a different mutation in the same dystrophin gene. In BMD, dystrophin isn't absent, it's just faulty.
So there's some of it, but it's either reduced in amount or it's an abnormal size or shape.
Precisely. So it provides some function, but not full function. This means the onset is later, maybe in late childhood or adolescence. The progression is much slower, and the lifespan can be near normal.
But, and I feel like this is a key point for anesthesia, the cardiac involvement can still be just as bad, can it?
That is a crucial point to make in your answer. You can have a patient with Becker who is still walking in their 40s, but has severe, life-threatening dilated cardiomyopathy. So just because their skeletal muscle function is better, you cannot assume their heart is okay.
Right. Good. Should I bother mentioning other types, like limb-girdle or myotonic dystrophy?
It's good to mention them briefly, just for a sentence or two. It shows the examiner you have breadth of knowledge. You can say, other dystrophies include limb-girdle, affecting the shoulder and hip muscles, and myotonic dystrophy, which is a multi-system disorder characterized by myotonia.
But then bring it right back to Duchenne.
Bring it right back. For the standard pediatric long question, Duchenne is the prototype. That's where you need to spend 90% of your time in detail.
Okay, let's get into that detail. The pathophysiology. This is where I think a lot of us can get tripped up, moving beyond just saying dystrophin is absent. How do I explain this elegantly to an examiner?
Use the anchor analogy. This comes straight from the core texts like Robbins and Miller, and it's a very powerful way to explain it.
Okay, the anchor analogy.
So dystrophin is a massive structural protein. Its physical location is just inside the muscle cell membrane, the sarcolemma.
Okay, I'm picturing it there.
Its job is to act as a mechanical link. An anchor. It connects the internal scaffolding of the muscle cell.
The cytoskeleton, the actin filaments.
Exactly, the actin. It connects that internal structure to a large group of proteins embedded in the membrane, which we call the Dystrophin-Glycoprotein complex, or DGC. And that complex, in turn, connects to the extracellular matrix.
So it's literally anchoring the inside of the cell to the outside.
It is the crucial bridge. It provides mechanical stability. Now, think about what happens when a muscle contracts. There are huge shearing forces generated across that membrane.
Right.
The DGC and dystrophin dissipate those forces, protecting the membrane. Now, imagine you cut that anchor chain, which is what happens in Duchenne.
The membrane is left fragile, unprotected.
Unprotected. So every single muscle contraction causes micro tears in the sarcolemma. The membrane becomes leaky.
And when it tears, things that should be outside get in.
Bad things get in. The most important one being calcium. You get this massive, uncontrolled influx of calcium into the cell.
And high intracellular calcium is a disaster for any cell.
It's a death sentence for a muscle cell. It activates enzymes called proteases, which literally start to digest the muscle proteins from the inside out. It triggers a cascade, leading to necrosis cell death.
And the body tries to repair this damage.
It does. There's a constant cycle of degeneration and regeneration. But over time, the destruction outpaces the repair. The muscle stem cells get exhausted.
And the lost muscle tissue gets replaced by something else.
It gets replaced by fat and fibrous connective tissue, adipose and scar tissue.
Which explains the classic clinical sign of pseudohypertrophy.
Precisely. You look at the boy's calves, and they look large, almost athletic. But when you feel them, they're doughy and weak. It's not muscle. It's fat and fibrosis. That is pseudohypertrophy.
Okay, now for the part you called exam gold, this isn't just a disease of the limb muscles.
No. This is the point that separates a pass from a high score. It's a systemic disease. The heart is a muscle. The diaphragm is a muscle.
So let's talk about the heart first.
You must discuss dilated cardiomyopathy. The same process of necrosis and fibrosis is happening in the myocardium. And Muller's anesthesia gives us a very specific detail here that's worth mentioning.
Okay, what is it?
The fibrosis often begins in a specific region, the posterobasal wall of the left ventricle.
Posterobasal left ventricular wall. Got it. That's a detail that shows I've read the source text.
It does. And this specific pattern of fibrosis leads to characteristic ECG changes. You see abnormally tall R waves in the right precordial leads, like V1, and deep narrow Q waves in the lateral leads, I, AVL, V5, V6.
It can look a bit like an old myocardial infarction.
It can, but it's fibrosis, not ischemic damage.
Yeah.
This cardiomyopathy is progressive and is often the ultimate cause of death.
Okay, and the respiratory system?
It's a progressive restrictive lung defect.
So the lungs themselves are healthy, but the pump is failing.
The pump is failing, the intercostal muscles are weak, the diaphragm becomes weak, scoliosis often develops, which further restricts the chest wall. All of this leads to a reduced vital capacity.
And a weak cough.
A very ineffective cough. This is critical. They can't clear their secretions, which puts them at huge risk for recurrent chest infections, aspiration, pneumonia, and eventual chronic respiratory failure.
So when we see this child in clinic, what are the classic clinical features we need to describe? We've mentioned the big, weak calves.
The story usually starts with delayed motor milestones. The parents will bring him in saying he's clumsy, that he falls more than other kids his age, has trouble running or climbing stairs.
And then there's the one sign you have to describe. Gower sign.
You must be able to describe Gower's sign vividly.
I can picture it, but putting it into words for an examiner.
You say it's a consequence of profound proximal muscle weakness, specifically the hip and knee extensors. So when the child is asked to stand up from a sitting or squatting position on the floor, they can't just push themselves up.
Right.
They have to roll onto their front, get onto their hands and knees in sort of prayer position, and then they literally climb up themselves. They put one hand on their knee, then the other, and push their torso upright by walking their hands up their thighs.
Climbing up themselves. That's a very clear description.
And diagnostically, what's the key lab test?
Creatine kinase, CK.
And what about it?
It's massively elevated, especially early in the disease.
How high is massively?
Like 10 to 100 times the upper limit of normal, maybe even more.
Good. We're talking levels in the tens of thousands or even hundreds of thousands. And why is it so high?
Because the leaky muscle membranes are just pouring their contents, including CK, out into the bloodstream.
Excellent. Now, let's get to the real heart of the matter for us, the anesthetic implications. This is the highest yield section. You mentioned the lethal risks earlier. Let's formalize them. I call it the lethal triad.
Okay, the lethal triad, risk number 1 has to be hyperkalemia.
It is. Now, I want you to explain the mechanism to me. Why does succinylcholine cause this catastrophic hyperkalemia in DMD, but not in a healthy child? It's not enough to just say the membrane is leaky.
No, it's about the acetylcholine receptors.
Hold on.
In a normal muscle, the nicotinic acetylcholine receptors are clustered at the neuromuscular junction, at the motor end plate.
Correct.
But in Duchenne, because the muscle is in this state of constant damage and repair, it reverts to a more primitive fetal-like state.
That's a perfect way to describe it.
And in that state, it starts to express extrajunctional acetylcholine receptors all over the surface of the muscle fiber, not just at the junction.
So the entire muscle cell becomes hypersensitive to acetylcholine.
Exactly. And these extrajunctional receptors are different, aren't they? They have a different subunit, a gamma, instead of an epsilon subunit.
And what's the functional significance of that?
They stay open for longer when they're activated.
Bingo. So when you give succinylcholine, which is an agonist, you don't just get a brief, localized depolarization at the motor end plate.
You get a massive, prolonged, full-body depolarization of every single damaged muscle fiber.
And the result of that is?
A tsunami of potassium efflux from the cells into the blood. It's not a small leak, it's a floodgate opening. The serum potassium can shoot up from 4 to 9 or 10 in a matter of seconds.
And the heart cannot withstand that. You get peaked T waves, a wide QRS, and then a systole or ventricular fibrillation. That is why there is no safe dose of succinylcholine.
Okay, that mechanism is crystal clear now. What's risk number 2 in the triad?
Rhabdomyolysis. Even without silicus, the stress of surgery, or particularly the use of volatile anesthetic agents, can trigger acute muscle breakdown.
And that releases myoglobin,
Which is toxic to the kidneys. It can precipitate in the renal tubules, causing acute tubular necrosis and renal failure.
And risk number 3. And this is the one that's always a bit fuzzy, the malignant hyperthermia question. Are they MH susceptible or not?
This is a point of nuance you must master for the exam. The classic teaching used to be the DMD patients were MH susceptible. Modern genetic testing has shown that they do not typically carry the specific RYR1 or CACNA1S gene mutations that cause classical malignant hyperthermia. So genetically, they are distinct conditions.
Okay, so they aren't technically MH patients.
However, and this is the critical part, as Miller makes very clear, they are known to have MH-like reactions to volatile anesthetics.
So they can develop hyperthermia, tachycardia, muscle rigidity, rhabdomyolysis. It looks exactly like MH.
It can be clinically indistinguishable. So what is your conclusion for the exam?
For the purpose of safety and for my exam answer, I treat them as if they are MH susceptible. I avoid all known triggers.
That is the only safe answer. You don't get lost in the genetic weeds during a crisis. You manage the clinical picture. And the safe management is to avoid the triggers.
And what about other drugs, non-depolarizers?
They're extremely sensitive. Remember, a significant portion of their body mass is fat and fibrous tissue, not muscle. So a standard dose of, say, rocuronium, calculated by weight, will result in a profound and prolonged block.
So you have to dose carefully and monitor the neuromuscular blockade very, very closely.
You might only need a fraction of the normal dose, and you must be able to reverse it if needed.
Okay, let's put it all together, the management plan. I'm faced with this case in the exam. Discuss your anesthetic management. Let's start with the preoperative assessment.
It has to be multidisciplinary and thorough, and you must specifically mention detailed respiratory and cardiac evaluations.
Okay, respiratory, what do I need?
You need recent pulmonary function tests, PFTs, and the key value you are looking for is the vital capacity, or VC.
Is there a specific cutoff value I should quote?
Yes, if the vital capacity is less than 50%, and certainly if it's less than 30% of the predicted value for their size, the risk of post-operative respiratory complications is extremely high.
So I need to have a discussion with the family about the likelihood of needing post-operative ventilation.
You must. That conversation has to happen before they even enter the operating room. Manage their expectations.
And for the cardiac assessment?
A 12-lead ECG and a recent echocardiogram are non-negotiable. The ECG is to look for those characteristic R and Q wave changes we talked about. The echo is to assess ventricular function.
I need to know the ejection fraction.
You absolutely need to know the EF. If it's less than 35 or 40%, this is a very high-risk anesthetic. Your entire plan for fluids, induction agents, and pressor support changes.
Okay, now for the big red flag section. The drugs to avoid.
I will say it one more time. You must state, clearly and with conviction, succinylcholine is absolutely contraindicated.
Got it. No ambiguity there. What about the volatile gases? Sevoflurane, isoflurane, desflurane?
Given their known risk of triggering rhabdomyolysis and their negative inotropic effects on a potentially failing heart, they are best avoided. It is not an absolute contraindication like Sux, but it is a strong relative contraindication.
So if I can't use succins and I shouldn't use gas, what is the recommended technique?
The gold standard technique is TIVA, total intravenous anesthesia.
Propofol and an opioid.
Yes. A propofol infusion for hypnosis and maintenance, combined with an opioid infusion, typically remifentanil or fentanyl, for analgesia.
Why is that safer?
because these drugs are considered clean for the muscles. They don't trigger rhabdomyolysis. They don't trigger MH-like reactions. And propofol is generally quite hemodynamically stable if used carefully.
Okay, TV is the way to go. What about the airway specifically?
You need to be cautious. These children can have macroglossia, a large tongue, and weak pharyngeal muscles. This bulbar weakness also increases their risk of silent aspiration.
So a careful, gentle laryngoscopy and a secure cuffed endotracheal tube.
Exactly. And then postoperatively, where does this child go?
Not to the general ward. They need to go to a high-dependency unit or an ICU.
Wow.
For close monitoring of their respiratory and cardiac status. Pain control is also a major issue.
It is. But what's the problem with using lots of opioids for their pain?
Well, it's a catch-22, isn't it? They're in pain, but opioids are respiratory depressants. In a patient with already weak respiratory muscles, it can be the thing that pushes them into respiratory failure.
So what's a great solution to mention in your exam answer?
Regional anesthesia. If it's a lower limb procedure, for example, a caudal or epidural block, or a peripheral nerve block like a femoral or sciatic block, can provide excellent pain relief without any systemic opioids.
That is an outstanding answer. It shows you're thinking about the complete perioperative journey. Ojiro.
Oh, Jero! Infantile hypertrophic pyloric stenosis, IHPS. Oh, dear.
Ojiro.
All right, Professor. Deep breath. We've navigated the Duchenne minefield. Now, a different scenario. The pager goes off. There's a 4-week-old baby boy in the emergency department. The parents say he's vomiting a lot.
Let's shift gears completely. Infantile hypertrophic pyloric stenosis, another absolute classic of the pediatric anesthesia exam.
So definition first. How do I define IHPS? It is the hypertrophy, which just means thickening of the circular, smooth muscle of the pylorus.
The pylorus being the muscular valve at the exit of the stomach.
Correct. This thickening becomes so severe that it causes a mechanical gastric outlet obstruction. Nothing can get from the stomach into the small intestine.
And the demographics are classic for this, aren't they?
Very classic. The textbook presentation is the firstborn male. It typically presents between 3 and 6 weeks of life. It's almost never seen right at birth, and it's very rare after about 3 months of age.
Okay, now for the pathophysiology. You said for this topic, this is the exam gold. It's all about the metabolic story.
This is where you really impress an examiner. You have to walk them through the biochemical cascade step by step. So the primary problem is the obstruction. What does the obstruction lead to?
Persistent, forceful vomiting.
And what specifically is in that vomit?
It's pure stomach contents.
Which contains what?
Gastric acid, hydrochloric acid, so H+ and Cl, and water, obviously.
Okay, so if you are losing large amounts of hydrogen ions, H+, what happens to your body's pH?
You become alkalotic. You develop a metabolic alkalosis.
And if you are losing large amounts of chloride ions, Cl?
You become hypochloremic.
Good. So the primary metabolic derangement is a hyperchloremic metabolic alkalosis. But the story doesn't stop there. The baby is also losing water, so they become profoundly dehydrated.
And the body's response to dehydration is to try and conserve salt and water. The RAAS system kicks in.
The renin-angiotensin-aldosterone system is activated. Aldosterone tells the kidneys to do what?
To reabsorb sodium from the renal tubules, and water follows the sodium.
Correct. But you can't reabsorb a positive ion like sodium for free. The kidney has to maintain electrical neutrality, so it has to secrete another positive ion in exchange. What does it secrete first?
It gets rid of potassium, K+N.
So the baby starts losing large amounts of potassium in the urine. Now, what is the metabolic state?
Hypochloremic, metabolic alkalosis, and now hypokalemic.
Very good. But this continues for days or weeks. Eventually, the body's potassium stores become severely depleted. The kidneys still want to save sodium to maintain blood volume, but they're running out of potassium to trade for it.
So they have to find another positive ion to secrete.
What's the only other one readily available?
Hydrogen ions, H+P.
Exactly. The kidney, in its desperation to conserve sodium and therefore volume, starts pumping hydrogen ions into the urine.
But wait, hang on. That doesn't make any sense.
Why not?
Well, the blood is already alkalotic, right? The pH is high. The body is desperate to hold on to acid, to hold on to H+ SOCHO. So why on earth would the kidneys start throwing away the very thing the body needs?
And that, my student, is the paradox. That is why we call this final stage paradoxical aciduria.
The urine becomes acidic, even though the blood is profoundly alkaline.
Because the kidney makes a choice. And it chooses volume over pH. It will sacrifice acid-base balance to try and maintain circulating volume and blood pressure.
Wow, that's a brilliant piece of physiology.
Yeah.
So the full 5-star diagnosis is hypochloremic, hypokalemic, metabolic alkalosis with paradoxical aciduria.
Say that exact phrase in the exam and you will get full marks for the pathophysiology section.
Okay, clinical features, we know they're vomiting. What's the character of the vomit?
It is famously projectile. The parents will say it shoots across the room, and crucially, it is non-bilious.
Non-bilious because the blockage is proximal to the ampulla of Vater, where bile enters the duodenum.
That is the key differential. If the vomit is green, containing bile, it is not pyloric stenosis. You must think of a more sinister cause, like malrotation with a volvulus, which is a true surgical emergency.
Anal examination of the baby.
The signs of dehydration will be obvious. A sunken anterior fontanelle, dry mucous membranes, decreased skin turgor, a lack of tears when crying. And then there's the classic physical sign.
The olive.
The palpable olive. This is the hypertrophied pyloric muscle itself. It's a firm, mobile, olive-sized mass in the epigastrium just to the right of the midline.
And I've heard it's best felt after the baby is vomited.
Yes, because the stomach is empty and the abdominal muscles are relaxed. It can be difficult to feel, but it's a pathognomonic sign.
But in modern practice, we don't rely on just feeling it, do we?
No, the diagnosis is confirmed by abdominal ultrasound, which will show the thickened, elongated pyloric muscle. The classic description is the target sign or cervix sign.
Okay, now for the most important part for us, preoperative management. I remember mantra number 2.
Remind me.
IHPS is a medical emergency, not a surgical emergency.
And why is that so critical? The surgeon is calling, they want to operate, the parents are distressed, the baby is losing weight. Why do we, the anesthetists, put our foot down and say, no, not yet? Because inducing anesthesia in a dehydrated, electrolyte-depleted, alkalotic baby is incredibly dangerous.
Let's break down those dangers. The alkalosis, what does that do?
2 main things. First, it shifts the oxygen-hemoglobin dissociation curve to the left.
So hemoglobin binds oxygen more tightly in the lungs, but is less willing to release it to the tissues, potentially causing tissue hypoxia.
Correct. But the more immediate danger is its effect on the central respiratory drive. Our drive to breathe is primarily regulated by CO2 levels and pH in the cerebrospinal fluid.
And if the baby is alkalotic, the brain's respiratory center is. Well, it's suppressed. It doesn't feel the stimulus to breathe.
Precisely. So you anesthetize them, you control their ventilation, and then at the end of the surgery, you extubate them, and they just don't start breathing again. Postoperative apnea is the single biggest risk we are trying to prevent.
So our job is to resuscitate first.
Our primary job is resuscitation. The surgery is a pyloromyotomy. It's an elegant and straightforward operation. The challenge is getting the baby physiologically safe enough for that operation. We typically delay surgery for 24, sometimes even 48 hours.
And how do we resuscitate? What's the fluid of choice?
You start with an intravenous bolus of an isotonic fluid, typically normal saline, 0.9% ACL, often 20 ml LPG.
Why normal saline and not something like Ringer's lactate?
Because what does this baby desperately need? It needs chloride to correct the hypochloremia and allow the kidneys to excrete the excess bicarbonate. Normal saline is rich in chloride. You also add dextrose to the maintenance fluids as these babies are starved and have depleted glycogen stores.
And potassium. Do we add that to the first bag?
Absolutely not. You never, ever give potassium until you have confirmed that the baby has adequate urine output. The mantra is no P, no K.
Because if the kidneys aren't working and you give potassium, you can cause fatal hyperkalemia.
Exactly. So you rehydrate with saline, wait for the diaper to be wet, and only then do you add potassium chloride to the maintenance fluids to correct the hypokalemia.
So what are my targets? What numbers do I need to see on the blood gas and electrolytes before I agree to proceed to the OR?
You need to see things normalizing. You want the serum chloride to be above 100 MEQL. You want the serum bicarbonate to be below 28. The pH should be trending down, certainly below 7.45. And clinically, you want good urine output, at least 1-2 millio-LQ/jar.
Until those targets are met, the baby stays on the ward getting IV fluids.
And the surgeon waits.
Okay, the targets are met, the baby is rehydrated, we're in the operating room. Anesthetic management. What's goal number 1?
Prevent aspiration. This is a full stomach case no matter how long they've been fasted. The stomach is obstructed. It's a stagnant bag of old, curdled milk and acid.
So before I even think about induction drugs, I need to empty that stomach.
You must. with a large bore orogastric tube, not a skinny little nasogastric tube. And you don't just put it on free drainage, you have to actively suction it. And you must perform what I call the suction dance.
The suction dance, I like it. What is it?
You place the baby supine and suction thoroughly. Then you turn them onto their left side, wait a moment for the fluid to pool, and suction again. Then you turn them prone, or at least head down, and suction again. You have to actively move the fluid to the tip of the tube to get it all out.
That is a fantastic practical tip. Okay, the stomach is as empty as it's going to get. Time for induction.
A rapid sequence induction, or a modified RSI, is the standard of care here.
Now, here's the big comparison question. Unlike the Duchenne child, can I use succinylcholine in this baby?
Yes. In IHPS, succinylcholine is safe and effective. It's not contraindicated. Its rapid onset and short duration are actually very useful for securing the airway quickly in this high-risk situation.
Though I suppose rocuronium is also a common choice now.
It is. Many anesthetists prefer a high dose of rocuronium for their RSI to avoid the fasciculations and myalgia of Succinylcholine. But the key exam point is that Succinylcholine is not forbidden here.
Okay. And for maintenance of anesthesia.
Inhalation agents like sevoflurane are perfectly fine. The surgery is quick, usually less than an hour. You typically use a short-acting opioid like fentanyl for analgesia, but you want to be judicious with it.
Because of the risk of postoperative apnea, we don't want a lot of opioid hanging around at the end.
Exactly. And that brings us to the most critical part of the end of the case, extubation.
They have to be wide awake.
Not just awake. They need to be wide awake, crying, with all their airway reflexes fully intact. The risk of regurgitation and aspiration is just as high, if not higher, on emergence as it is on induction. There's no room for a deep extubation here.
Got it. And postoperatively?
They need close observation, typically in a NICU or a specialized pediatric unit. You're watching for two main things.
Apnea and hypoglycemia.
Apnea, especially if the alkalosis wasn't fully corrected, and hypoglycemia because their glycogen stores are so low, they need regular blood sugar monitoring. You also continue to monitor fluids and electrolytes.
Pain management.
Usually simple analgesics like paracetamol are sufficient. The surgeons often infiltrate the wound with local anesthetic. The pain from a pyloromyotomy is not usually severe.
And when can they start feeding again?
Relatively soon. Most protocols start feeds within a few hours of surgery, and the vomiting usually resolves immediately.
Comparison and integration. Right.
Okay, Professor. This has been brilliant. We've gone deep on both conditions. Now for Part D, where we bring it all together. Let's say I'm in the Viva, and the examiner leans back and says, all right, compare and contrast the anesthetic challenges of Duchenne muscular dystrophy and infantile hypertrophic pyloric stenosis. Where do I start?
You start with the fundamental nature of the disease. DMD is a chronic, progressive, genetic neuromuscular wasting disease. The risks are inherent to the muscle cell itself.
Whereas IHPS is an acute anatomical problem leading to a reversible metabolic crisis.
Exactly.
Right.
One is a lifelong condition we manage. The other is a temporary state we must correct before surgery.
And then I'd move to the primary killer risk for each one.
What are they?
For DMD, the killer is sudden hyperkalemic cardiac arrest on induction. It's an electrical and pharmacological disaster.
Good. And for IHPS?
For IHPS, the killer is either aspiration of gastric contents on induction or emergence, or respiratory arrest from postoperative apnea. It's a respiratory and metabolic disaster.
Excellent contrast. And now, the most important point of comparison, the drugs.
Succinylcholine.
Tell me.
In Duchenne, succinylcholine is an absolute contraindication, a lethal weapon. Giving it can kill the child. In IHPS, succinylcholine is a safe and acceptable option for a rapid sequence induction.
If you make that single point clearly, you have already demonstrated a huge amount of core knowledge and safety.
Okay, let's play a game. Viva Traps. You're the grumpy external examiner. Throw me a curveball.
All right. Adopts a sterner tone. Doctor, the surgeon, is on the phone. He's agitated. He says the 4-week-old with pyloric stenosis is vomiting uncontrollably. The parents are hysterical, and he wants to take the child to theater immediately to, and I quote, stop the losses. What do you say to him?
Okay, right. I say no. I say respectfully, no, we cannot proceed.
He's not happy. He says you're delaying definitive care.
I would explain that this is currently a medical emergency, not a surgical one, and that inducing anesthesia in this child's current metabolic state would be life-threatening due to the high risk of postoperative apnea and cardiovascular instability. I would state that I will be ready to proceed once the child has been adequately resuscitated for 24 to 48 hours and their electrolytes have normalized.
Normal tone. Very good. You held your ground based on safety. You passed that question. Let's try another one. Doctor, what muscle relaxant were you used for the 5-year-old Duchenne child undergoing a tenotomy?
My first choice would be to avoid muscle relaxants entirely if possible. I would aim for deep anesthesia with propofol and remifentanil, which may provide adequate intubating conditions on its own.
And if you can't intubate, if you need relaxation?
If I absolutely must use a relaxant, I will use a small, carefully titrated dose of a non-depolarizing agent like rocuronium, guided by a peripheral nerve stimulator, and I will state for the record that I will never use succinylcholine.
Excellent. One more. A tricky one. You're working in a peripheral center. Your blood gas machine is broken. You have a baby with suspected IHPS. How can you gauge the severity of their metabolic alkalosis before transfer?
Oh, that's a tough one. No ABG.
Think about the basic chemistry panel. What ion is the mirror image of bicarbonate in this condition?
The chloride.
Go on.
Because they're losing HCl, for every H plus they lose, they also lose a Cl. And for every H plus they lose, the body generates a bicarbonate ion to compensate. So the low chloride should reflect the high bicarbonate.
So what's the expert trick?
Look at the serum chloride. A very low chloride level is a strong surrogate marker for a severe metabolic alkalosis.
That is a very sharp answer. Well done.
Okay, let's talk about exam presentation. If I'm writing a long answer, should I use diagrams?
Absolutely. A simple, well-labeled diagram is worth 100 words.
What would you suggest for DMD?
For Duchenne, draw the sarcolemma. Draw the actin filament inside. Then draw the dystrophin protein as a bridge connecting the actin to the dystrophin-glycoprotein complex in the membrane. Label it the molecular anchor. It immediately shows the examiner you understand the fundamental pathology.
And for IHPS?
For IHPS, don't draw the anatomy, draw the process. A simple flowchart for the fluid and electrolyte management. Box 1, bolus 0.9% saline. Arrow to box 2, assess urine output. Arrow to box 3, if 1 ml KRCR, add KCl to maintenance fluids. Arrow to box 4, monitor electrolytes until CL 100, bicarb 28. It's clean, logical, and very easy to grade.
Professor, this has been an absolute masterclass. Before we finish, can we do a rapid-fire summary? The absolute must-know take-home points.
Let's do it. High-yield bullet points.
Go.
For DMD, think weak muscles, weak heart, weak cough. Pre-op echo and PFTs are mandatory.
The anesthetic technique is TIVA, total intravenous anesthesia.
Absolutely, and no succinylcholine. Be extremely cautious with volatile agents. Treat as MH susceptible.
And expect post-operative respiratory weakness. Plan for HDU or ICU care and use regional anesthesia where possible.
Perfect. Now for IHPS.
It is a medical, not a surgical emergency. Resuscitate first.
Correct. The hypochloremic, hypokalemic metabolic alkalosis over 24-48 hours.
Empty the stomach with a wide-bore OGT using the suction dance before induction.
Perform a rapid sequence induction. Sucks is safe here. Extubate wide awake.
And monitor post-operatively for apnea and hypoglycemia.
You've got it. The final thought I want to leave you with is this. These cases demonstrate that an anesthetist is not just someone who puts people to sleep.
No, we're the internal medicine physician of the operating room.
You are the perioperative physician.
Yeah.
You have to manage complex genetics, fluid balance, and metabolic derangements before you even think about reaching for the propofol. That is our specialty.
A powerful thought to end on. Thank you so much, senior faculty, for this invaluable drill.
My pleasure. Now go and pass that exam.
And for all of you listening, I really hope this helps. The key is to visualize these patients. Picture the 5-year-old boy using his hands to climb up his own legs. Picture the tiny 4-week-old hungry, vomiting baby with the sunken fontanelle. If you can see them in your mind's eye, the management steps become intuitive. They're not just a list of facts to be memorized.
Because knowledge is safety.
Exactly. Thanks for joining us for this special edition of The Deep Dive. Good luck with your studies, and we'll see you on the next one.